Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I am the CEO and managing editor for BBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Avery Telehealth. And this one is called Conquering Readmissions, Proven Strategies and the Power of Digital Health in Value-Based Models. I think you're really going to enjoy the presentation today. I got a little bit of a sneak peek before we did this during our practice run and going to be covering a lot of great material. A few items of note before we get started. This is a traditional webinar format, so you have joined in listen only mode, so you don't need to worry about turning off your mic or your camera. We can't hear you or see you, but we do want to hear from you, and we are going to have a time for some Q&A towards the end of the presentation. So if you have a question for either of our speakers at any time, go ahead and drop that question in to, there's a little module that you have as an attendee, and we're going to get to as many as we can. We do have a big audience today, so if we don't get to yours for some reason, don't worry, someone will reach out via email afterward to make sure that we get your question answered. And finally, the session today is being recorded, so what's going to happen is when we conclude, maybe about an hour or so afterwards, you're going to receive an email to the link. It'll have the link to where you can view the recording as well as download the slides. And that way you can review it at your leisure and share it with colleagues and friends, and we hope that you do. So without further ado, wanted to very briefly introduce our speakers today. With us, we have Mr. Mark Aspenson. He is the Chief Executive Officer for Avery. And then we have Mr. Daniel Taylor, and he is the Chief Nursing Executive. So welcome, gentlemen.
Thanks, Garrett.
I'll turn it to you, over to you at this time.
All right. So, Garrett, thanks so much for the opportunity to present today. You have a very diverse crowd that's with us. We have a lot of ACOs, health plans, health systems, physician groups. So we'll talk, predominantly about where it comes to readmissions in a broad scale, but also where our specialty really is when people are actually get home. So that's what we'll talk a lot about today. So as you kind of recall, in 2009, they passed the Hospital Readmission Reduction Act, which started tracking hospitals' readmission rates specifically for heart failure, pneumonia, and AMIs. And then in 2013, Medicare started penalizing hospitals for excess readmission. So in theory, you probably all heard, back in the day, if you're a Medicare patient, you had a 20% chance of being readmitted in 30 days. So 1 in 5 people would be readmitted in 30 days. I mean, if you talk about quality, you would take your car in for service at a place that you had a 20% chance of being back in the shop within 30 days. So what we're going to look at today is not just a readmission number, but specifically diving into specific diagnosis and then also what you can kind of do about it. So at broad temps, this is the most frequent admissions to the hospital, regardless of diagnosis. So sepsis has taken over. It used to be pneumonia at 2.2 million. The average cost for sepsis on admissions is $41 billion a year, so it's pretty expensive. Also, each time they go in, it's $18,700. So it does, these initial admissions get expensive, but also the readmissions are quite expensive as well. And here's kind of a good slide as far as the average cost and the number of stays as well. All this data is coming from HRQ, or we like to use a health service organization for QIOs to get a lot of our data, so we're not just making this up on our own. Here again, here's your actual readmission rate. So sepsis has a 17.7%. Heart failure is still really high at 21.9%. So if you look at, those are just still the top 20 most frequent admissions to the hospital here. But then let's look at the cost. So if your average cost for your index admission versus your readmission costs, so there's 19 of them on here. There's only 6 of them where the readmission cost is less than their index admission. So readmissions are costing more than just their initial stay. And then on average, your overall, it's a little bit difficult to see here, but overall for any diagnosis, the cost is $14,500 for the index, and the readmissions is $16,300. So you have a 12% increase in readmission costs versus the index. Also, when you're looking at, well, where is the trending of readmissions kind of going? Also by location and race and ethnicity, as well is important. You're really kind of seeing it hasn't changed a ton. It has gone down a little bit, but it really doesn't matter. It's not a, we have people from all over the country today. It doesn't matter when you're a large central metropolitan area or a rural area, you're still going to have some readmission problems. Race is not a huge issue when it comes to readmissions. The Black population has a little bit higher readmission rate than others. And the payer source really doesn't change. If you're looking at Medicare from 2016 to 2020, from 17.1 all the way down to 16.9, but then back to 17. So it really hasn't moved a whole heck of a lot as far as the payer source when it comes to readmissions. You also want to look at, well, where are they being discharged to, right? So about 90% of patients are being discharged home. And then you want to look at when are the readmissions, coming back, from which location are they coming back. Other great statistics, this is from HSEG as well, is what days are they being readmitted? Do you need to front load visits? Is it, your entire 30-day period that you have to look at? And also from, where are they being readmitted? So kind of an interesting stat here is home health. Everyone says, front load all of your home health visits. Well, if you're looking at you got 30% of the readmissions are occurring on days 22 to 30. So you can't really just say la vie after the first 10 days of a home health visit. Here's just another chart that kind of shows when patients are being readmitted and where they readmitted from. So keeping in mind that they're not always being readmitted specifically back to the same hospital as well. So what we want to also talk about now is kind of, well, what are historically the typical strategies about reducing readmission? So if you look at Project Red, reengineering discharge, Project Boost, better outcomes for elders, and then you have Coleman's model for the 4 pillars. Keep in mind all of these readmission strategies are related to hospital-based while the patient is still in the hospital, right? So they're really talking about starting readmissions from transition planning from day one. Well, if you're in the hospital and you have a hospital program, you can start that. But if you're a health plan or an ACO and you don't know that they were admitted or weren't aware of it, it's kind of hard to do some of these, pre-discharge planning. You certainly want to have, look at some of the traditions of patient understanding the condition, empowering them, making sure that they understand why they were in the hospital as part of a certain strategy, that has been put in place. Also looking at their social determinants of health of, what is their housing situation? Do they have access to food? Or do they have access to the medications? Those are all kind of typical strategies that have been put in place before. Following up, you've heard some of the scenarios of the situation background assessment recommendations with post-acute care. When they're discharged home, getting a hold of the people, making sure that you have the correct phone number for them. Oftentimes, if they're in the hospital, they may give you a different phone number because they think you're going to send them a bill, or sometimes maybe they're not going home after the hospital stay. Maybe they're going to go live with their daughter. So how do you get a hold of the daughter? So those are important things to kind of keep in mind when you're looking at strategies to reduce readmissions. Obviously, having a telehealth solution is a key part in access to the overall health for the high risk patients, making sure they have the tools to be necessary to keep them out of the hospital. And then, everyone talks about having a PCP visit. Well, schedule a PCP visit before they ever leave the hospital. Don't wait and leave it up to the patient or the member to do that. So now we'll kind of bring Daniel in to talk about kind of some proven strategies. So Daniel, why don't you kind of take over at this point?
Thank you, Mark. Appreciate that. I always like the opportunity to talk about patients and readmissions and things like that. I've been in community health for the past 15 years. Came out of the hospital, working in the cardiac unit with cabbage patients and things like that. The It was always interesting, the patients that we discharged from the hospital. You had the newly diagnosed, whether it was heart failure or diabetes, things like that, or you had, we all know, the frequent flyer, the one that, that comes in, they come up to they usually know what to do before we ever get there. So we had that goes from one spectrum to the other. So new and an old timer that kind of done this rodeo before. When I went into home health after the hospital, I got to see some of those patients and why they were coming back to the hospital. Because when we were in the hospital, we did a real good job. Mark talked about, hey, go ahead and make that appointment for, the patient. So they've got an appointment to go see their PCP and things like that. And when they're in the hospital, even the ones that are newly diagnosed are confident. They understand, they got their instructions, they got the meds, they say they've got it. Same thing with the frequent flyer, they got it. The problem is that's a good controlled environment. You've got clean, well lit floors. Nothing's in the floor. You don't have no throw rugs. You don't have things that they can trip over. They don't. It's not an uneven surface. Things like that. So it changes. The environments change. So when they get home, that kind of the whole part of the plan of care process changes. And really, it comes down to three goals. When you look at it, it comes down to three goals. And I'm going to go ahead. You got the first goal is really just early intervention. So you've got the early intervention goal, and then you got goal number two, which is oversight. We'll talk about that. That plays a huge role. And then three, which is connecting the dots. All the healthcare providers and clinics that are attached with that patient, making sure that they're able to get to that point. When a patient comes out of the hospital, it's important for someone, a healthcare professional. I'm a nurse, so I'm going to say a nurse reaching out to that member in the first 24 to 48 hours. It's critical that you do that at that point. Now, we can reach out to them by phone. We can reach out to them by, virtual visits. I love virtual visits. Did that in the home health arena. Did that in the telephonic nursing in the home health arena. I've done it in the arena I'm in now with Avery. And I see things that we can do to help these members so they don't go back to the hospital. But that first 24 to 48 hours is really crucial in making sure that we get these patients the information, because when they get home, where it was so clear in the hospital and all they focused on was, okay, I gotta understand this. This is new. I got, so I don't come back to the hospital, and they're focused on getting back to the hospital, but then they get home and we're confident they got this. They get home and they're thinking about work, and they're thinking about all these other things, families coming over, and then they go to their discharge instructions, if they still have them, of course, and they look at them and they go, what does that really mean? I thought I had this, at that point, it's really good when a nurse can call and say, hey, you want to go over your healthcare, your plan of care. Just something as simple as do not lift, do not push, don't pull anything over 10 pounds. We've all heard that, especially post surgery and things like that. What does that really mean? I mean, it's pretty clear, I shouldn't take out the trash. Well, I like that. I'm not going to do it for a couple weeks now. My grandchild comes to the house. I runs over. I can't pick her up. That's easy. But what about I'm running to the store, or I'm going to drive down, and all of a sudden, halfway there, you get a flat tire. So you can't pick the tire up. So someone helps you. They pick up the tire and they put it in there. But while they're doing that, you're going to break the lug nuts, or the bolts that hold the tire on. They don't understand the force and pressure that it takes to do that. Do they really understand? Or the patient that they got their medications, maybe they're albuterol, and they go home, they get their medication, but they don't have a nebulizer to change it into a mist for the breathing treatments and things like that. It's important we cover those discharge instructions so they understand exactly what what they mean. They take that literal. So when they read it, it's literally this. All right. Don't lift, push, or pull. All right. But So you going over those instructions when they get home is really important because it's confusing at that time. But then you got the med list. What do I do with the med list? All right, I've got these are what I was taking at home. These are the medicines they told me when I came home. These are the ones that I should be taking. I look at both lists, and they're exactly the same except for two medications. So what do? They take those two medications. They go, that's the same list. I'll take these two. I'll put it over here. I'm good to go. No way I can mess that up. And then, but they don't realize that sometimes the same class of medication, and I've seen this on so many occasions, are changed. It's a different drug, but it's the same class, like a beta blocker. Maybe they were taking metoprolol. Then they switched over coming out of the hospital, they want them on Corvedalol. They want them on that. Instead, remember, they just added it to the med list. So now they're taking both of those. What's going to happen then? We know what's going to happen then. They're going to have a very low heart rate. I actually one time saw where someone said, don't stop this medication no matter who tells you. They didn't stop it. We had a 30 heart rate. Well, we were going back to the hospital, but same thing. You go to the, they think about the diabetes medications, or maybe they're newly diagnosed patient with diabetes, and then all of a sudden they get home. They've got this insulin. They told the hospital they had a glucometer, but guess what? They don't have a glucometer. It's broke. you know. So how are they going to check their blood sugars if they don't have a working glucometer, but they're going to continue to give their insulin? So many times we've ran into that situation.
Yeah. So
So,
Daniel, what do you find out as far as, we're looking at kind of some of the top 10 proven strategies to reduce the readmissions. If you kind of, I don't know if we need to hit on all of them today, but at least if you want to talk about just kind of the first two, to start, then we can kind of hit on some other ones.
yep. And we talked about the discharge awareness, the engagement, and someone getting in front of them. So it's really important. That's in that first 24 to 48 hours. After you've done that, you've got to make sure. Mark brought up a good point. Schedule them a PCP appointment. That one's huge, Mark. Because
Mhm.
it's not, I know when I was in there, we tried to do that, but the, doctor's office wasn't always open or things like that. You've got to do that. You got to, so many times the PCP doesn't even know that the patient's in the hospital or even went to the ER. So that's a really big one that you've got to do. And even following up with other specialists, whether it's a cardiologist and endocrinologist as well. So,
And
and
I
that
think,
kind of takes us into goal number 2, which is oversight. And that's that's that nurse coming in and helping that member make the right decisions, and self-management starts there. And I think, Mark, you talked about self-management just a little bit when you were going through the numbers of
yeah,
getting these patients to
yeah, I
take
think,
control.
yeah, when you talk about self-management, we oftentimes, if you look at heart failure readmission programs, every cardiologist or physician is going to tell the heart failure patient to weigh themselves every day. And then if they gain more than 2 pounds in a 24-hour period, to call them and maybe they adjust the medication, so on and so forth. But what we found is that 50% of the time, the patients don't even have a working scale in their home. So it's not that they're not compliant. It's like they just don't have the tools to be necessary towards self-management. So, if they are a heart failure patient before their discharge or even after, it's finding out, do you have a working scale in your home? Do you have a working blood pressure? Those type of things. For COPD, you want to make sure they have a working pulse oximeter. You talked about diabetes for glucometer. So that making sure that the tools, it's kind of hard to call someone if you don't have the tools in order to know when to call them. And I think, to talk about the engagement, which you had mentioned, is that you can have the best program in the world and you can be great at readmissions, but if no one's participating in your program and you don't have any engagement, you're done, right? I mean, it's just, I have a program. So I think, if you want to talk a little bit about kind of speaking their language as well, as far as getting that engagement, Daniel.
Well, and it always is, because they have the equipment, like Mark said, or I'm an advocate of the RPM, remote patient monitoring, and things like that. Is what does the data mean? It doesn't do any good if they have it, but then they don't know what to do with it. What is this important that it's 160, or is this important that it's 74 for a heart rate, things like that. But you got to help them understand that. Mark brought up the point of 2 pounds, making sure they understand what 2 pounds overnight in 24 hours means for a heart failure patient. And then what about the 5 pounds? Well, you only told me I had 2 pounds overnight, but they gained, over 5 days, they gained 1 pound a day for 5 days. Guess what? Yeah, they're not 2 pounds overnight, but now all of a sudden they're 5 pounds. So it's making sure we understand how they're looking at it and seeing it, Mark.
Well, I think also to your point is understanding the why. Is if you're going to gain more than 2 pounds, well, why should I call you? Like, does the heart failure patient even know why that's important, or like what's in it for the patient? To call, and also the other symptoms, signs and symptoms here on the education for number 8 of when to seek help is, does the patient really know, why to seek help, and when to seek help? So. I think getting back to, as far as the engagement goes, to speaking their language is, you know, we're talking to a lot of different parts of the country, today, and we talked with CEO for a health plan in Nashville last week, and they're like, if you want our patients to engage with you, or our members to engage with you, you need to have someone that speaks that same accent too. It's not just even English, or right? And we had someone from New Orleans, like, you need someone that speaks Creole, right? So if it's a Russian speaking patient, you need a Russian speaking nurse, to reach out to them. So I think those cultural needs that I don't think we pay enough attention to, your readmission programs really cannot be a one size fits all program.
Mark, you talked about the language barriers and things like that. That is huge. The We're finding that when we have, like with the Hispanic population, we're making a tremendous surge in that market right now, in a
Hmm.
lot of different areas because of, when they answer the phone, they've got someone that can talk and speak in their language, in their verbiage, and just and believe all, there's always a different dialect from the, like you said, from the south to out west to up north. Something I learned this week, just so you know, just because they speak Russian doesn't mean they want you to talk to them in Russian. They want you to speak to them in English, and then they'll speak in Russian if we need to. So there's cultural things there to learn, and I'm learning. I learn stuff like that every day, as far as in their language. Yeah, absolutely.
So a lot of the traditional programs, whereas Project Red or Boost, right, they're really talking about doing a lot of education prior to discharge. And then during this risk period, which is a 30-day risk period, right, they're making what? One call 48 hours and then another call a week later. So in a 30-day risk period, they're only making 2 outreach calls. I mean, how are you really going to bend the needle for that? So talk, Daniel, a little bit about from a clinical outreach, from a frequency standpoint, we kind of have here as number 10 is the minimum, is within the first 48 hours, but you really got to have a weekly proactive call.
Well, think about it. What are we doing different? All right. And it's no fault of a hospital, someone at the hospital, or someone at a doctor's office. When they do provide them education, go over their meds, go over their discharge plan, all that information is being flooded in. It's information overload. So it's all being before, because that might be the only time we get to talk to them. So if that's the only time, then we're trying to get them to understand as much as we can. But really, it's, we're throwing spaghetti on the wall, hope it sticks, and it's done. But it never sticks. All right, that's why we get
Mhm.
these frequent flyers. So we have to break this down in manageable pieces for them. We can't just automatically, and everybody's a different learner. They're all at a different learning stage. And that's where health literacy comes in. I had one of my colleagues the other day, meet the patient where they are. I get that. I get that terminology. You got to find out where that patient is, and then we can start breaking down this information so they understand it. Mark's put up there, this was a heart failure pathway. What I like about this is, yeah, he talked about front load. Front loading is important. You don't, touching them, a little bit more frequent the first week, the second week. You can, I've seen it. over, 11, 12, 13, whatever it is, years that I was in home health. Mark's right. The first 7 days and days 15 to 24, yeah, it's like we dropped the ball after 2 weeks. They've got it, they don't. Um, so it really is kicking in, and everybody forgets about day 30, 31, getting their medications refilled. It really is stretching it out over the course. Now, and you got to remember, this isn't me calling them, this isn't me going in their home every time you see a marker on there. This is patients are liking the fact of a telephone call, but then they don't have time for a call, so they'll text, and then they look at an answer, and then they might answer us an hour later, but that's okay because it's
Mhm.
on their time. Virtual visits. I like the utilization of virtual visits because I was seeing a patient the other day on a virtual visit, and we told her to zip on down to Walmart, and get what she needed. Well, and she said yeah, it's really hard for me. We didn't understand why it was really hard for her to just zip on down to Walmart. When we got her on camera, we were able to have that face-to-face interaction with her. We were able to see the fact that, man, she's exhausted, just standing on the counter, over the counter, talking to us. And
Mhm.
here we are. If we hadn't have done that virtual visit, we'd have just said, zip on down, Mark. So you
Mhm.
have to break the information down, manageable pieces where nobody remembers anything the first time. All right. I the doctor tells you something, you need to think about it. You might not get it. It might take two or three times. So you want to be able to do that. What's the cost of a phone call? What's the cost of a text? It's a lot cheaper than three $3,000 for a certain period of home health. It's
Yeah.
much less than the cost of, what was that, 14,000 or 18,000, Mark? You said for heart
Yeah,
failure
it's about
readmission.
yeah,
Yeah,
it's about $16,000 for the average
yeah,
readmission. And I think the key is that we should have different programs based on their engagement preference, right?
yep,
So,
absolutely.
texting is becoming far more popular. Most people don't even want to talk on the phone. They'd rather just text with someone. So, if you can have a outreach program that's text-based, if you can outreach program that's phone-based, and then even emails as well. And how does that individual patient or member, what's their engagement preference, and have different programs for both. So I think that that's a key, and you're right, to spread it out over the entire 30-day risk period versus just front loading everything and or only having two phone calls, right? And as you're
Yep.
talking about, a lot of the texting programs are very affordable, emails very affordable. Obviously the phone calls and the video visits are just a little bit more intense. You get more from them, but sometimes it's just a little bit more costly to do that. So we give you guys some strategies. Let's talk about kind of when you're looking at conquering readmissions. We have kind of, again, here we have kind of our index admissions, and each one of these from a readmission standpoint is more costly. So if you're able to just reduce these readmission rates, say you're able to reduce it by 30%, your savings per thousand for each one of these is going to essentially be $1 million per thousand lives that you're covering, which is great, right? If you total it up, you're at, investing in a readmission program is your ROIs are going to be huge if you're able to reduce it by 30%. But let's say, for instance, you've seen some of them that have been savings at 40%. Now you're really going up, right? So, now your total savings are over $7 million per thousand, right? There's a lot of things you can do with additional $7 million, per thousand as well. But we've seen a lot of programs where they have actually even done more than 50% or more reductions by putting in some of these strategies. So, the numbers really, and then keeping in mind, really your costs for these reductions are pretty much the same, whether you're reducing by 30%, 40% or 50%. So your ROI is really going to be really skyrocketing when you start to get these huge, 40, 50% reductions in savings. So we're kind of halfway through. So we wanted to open it up for kind of questions. So Garrett, you want to kind of take over the Q&A section for us?
Yeah, that's right. And we do have some audience questions here. So If you have a question that you would like to ask either Daniel or Mark, go ahead and drop it in now using your attendee module. There's a little spot for questions there. If we don't get to yours for some reason, don't worry, someone will reach out to make sure that we get that answered. So in no particular order, first question is this. In your experience, which patient populations are at the highest risk for avoidable readmissions, and how should strategies be tailored to them?
You want to start with that, Daniel?
Yeah, absolutely. The honestly, the highest risks are the ones that have SDOH needs, your standard determinants of health needs. They're lacking resources in the home. That maybe they don't have the power, maybe they don't have their food, they don't have transportation to get to and from work. And the why that takes, well, think about it. You got to put food on the table, a roof over your head, and you got to get back and forth to work. I don't have time for my health care needs right now. I've got to do this. I feel fine, but what they don't know is that's creeping up on them on time. So those that are really needing those, those just resources that so many of us take for granted, uh, healthcare kind of gets put in the background with those.
Yeah, I'd say probably from a diagnosis perspective, if you're to group everybody by diagnosis, I think heart failure you're able to reduce readmissions the most because a lot of it is tools and education where a lot of them don't have the tools and they don't understand the signs and symptoms. COPD is another one where you can really kind of bend the needle. Pretty much, I think the hardest one to reduce readmissions, unfortunately, is sepsis. Like it is just,
Mhm.
it's super hard. Once that infection gets in there, I mean, we're able obviously to make sure that they take their medications, take their temperature, like that kind of stuff, the best that you can. But there's not a ton of education you do to help prevent sepsis. And then, some of the cancers as well are tough to reduce readmissions. Those are probably the two that are the most challenging to make a significant bend in your readmission numbers.
Mark, I also want to add to that. You've got you on the, I was there's 1.2 million newly diagnosed patients with diabetes every year. All right. There is 8.7 million across adults in the U.S. This is all, the ADA's done the research on this across the U.S. that haven't been diagnosed, with diabetes. So, and I don't know if you guys know, you probably do, but the number one cause of cardiovascular disease, Mark brought up heart failure, MI, things like that, is diabetes. So it's kind of a double whammy there. So that population, so when you get
Yeah,
into heart failure and diabetes, you got a big population there.
well, and to your point, Dan, you got to take care of the entire person. You can't just take care of the one kind of admitting diagnosis. So we talk a lot about heart failure, but exactly to your point. So if someone's enrolled in a heart failure program, 40% of the time they also have diabetes. So the chances of a lot of these chronic conditions where you only have one condition to take care of and there's not multiple comorbidities going on here is very low. You got to take care of the entire person.
Great. Next question is this. How can organizations balance proactive monitoring with avoiding alert fatigue for clinicians?
This is where you cannot have a one size fits all readmission strategy and or program, right? It is, the frequency in which you engage with the members is extremely important, right? And it's more important that they maintain their engagement than follow the strict protocols that you have in place, right? So, there's sometimes, we talking an example of a Medicaid, member that we've had in the past that had limited cell phone minutes, right? So he didn't, particularly want calls or even text messages because it was going to run out his minutes and his text messages for the month. So, make a plan with the individual. What we did is make a plan. Well, we're just going to call you once a week, right? However, if you experience any of these symptoms, you need to call us, right? So that's the way to keep a member engaged, even though they have a limited cell phone minutes. Same thing if someone has a job, like if they can't take your call and they want to go to work or whatever the case may be, making sure that they know, when to really seek help is really a big piece of that. Daniel, do you want to add to that, or?
Yeah, you covered it pretty well, Mark. It's just really comes back to that patient-centered focus, the head to toe of what's going on with that patient, making sure that we're meeting all their needs from every avenue we can, making it an easier life for them.
Yeah, and Garrett, to that fatigue question, everyone's trying to reduce readmissions, right? So sometimes they'll get calls from the hospital that's following up. They'll get calls from the doctor's office to follow up or schedule appointment. They'll get a follow-up call from the health plan because they just got alerted to the admission and find out, well, why did you there, right? So they may have a home health visit. So they may be getting it from 5 different places. So really kind of coordinating that care transition plan of who's doing what and when, right? A lot of the ACOs have their own care coordination as well. So making sure that who's calling and when, or visiting and when.
Well, we talked about, I was going to have just a couple more things. We talk about, technology and getting technology out there. And a lot of times when, if you use telemonitoring or something like that, or even, their CGM, continuous glucose monitoring, it's really setting the parameters where they need to be for that patient, or else, going back to what Mark was talking about, the alerts, it's every time, doctors are getting, the PCPs get an alert for this, the nurses get an alert for this. Someone's got to do something, and it does become exhausting. And then it really goes back to the way we teach. It goes back to that language that Mark talked about earlier, as far as teach back. When we tell them something and give them information or show them how to do something, let them not just teach it back, but let them tell you back, how they understand it, to make sure their understanding is right, or it's just going to be, a circle of just going back and doing the same thing over and again, reinforcing.
Yeah, very good. Yeah. Next question here is, how do you capture patients that discharge from a hospital outside of your health system?
Well, if it's outside the health system, you really want to have the HIE feeds. So we're fortunate enough to have HIE feeds, a nationwide network of HIE feeds. If you look at the people that are discharged, I think it's 40% of people that are readmitted are not readmitted to the same hospital. So even if you're doing these internal programs and you're keeping track of your own internal readmission numbers, when you get the stats from Medicare and your numbers are higher, like, you just kind of have to factor in that they're getting readmitted to a different health system as well. And that is certainly a challenge, and that's why keeping track and doing proactive outreach at least once a week, hopefully if they do have to go back, that you have a relationship with them to go back to that same hospital. They had a good experience at the same hospital. So unless you have the HIE ADT feeds, it's extremely challenging.
Yeah. All right. And by the way, I noticed that a couple of you have hands raised. So if you have a question, go ahead, and instead of us calling on specific hands, go ahead and drop your question into the question place on your module there, and then we'll get to it in that way. Next question here is, let's see, I liked the heart failure pathway. How many patients per nurse are you referring to? I have 80 to 90 patients per rolling 90 days. I could not make that volume of calls and text on that many patients. What is a comfortable ratio to make a program like this work?
Yeah, so the good news, you want to have a platform that knows where the patients are in the pathway, right? So typically they're able to handle about 125 to 150 is what our nurses are able to manage on a heart failure pathway. Keep in mind, if you go back to that, if I can go back to that pathway real quick, I think.
Yeah.
It's not all phone calls, right? So,
Right.
sorry, I'll go back here. So some of them are text messages, some of them are emails. Sorry here. So if you look at, you have a DASH diet here, that's an email related to DASH diet. You have an action plan, that's an email. Some of the medication adherence reminders to take the medications are text messages. The importance of taking your weight and why you want to take your whether it's a LASIX, whatever the case may be. Those are text messages. So use technology to help you and to help engage with the member versus you don't have to rely solely on phone calls.
Right.
Great.
That's a good question.
That was a good question. Next question is this, and there's a fun fact about this question. This is posed by my sister,
Ah,
who's Stacy Robinson. She is a care coordination nurse at UF. So
great.
welcome, Stacy. Glad to have you with us. And her question is this: what role does artificial intelligence play in reducing hospital admissions after patient discharge?
I think it's going to be huge. I think it's a little too early to the party as far as getting results related to AI. But as much data that we're bringing in there, ultimately they're going to know based on all data that you're inputting into AI, they'll tell you the day that they're going to be readmitted, right? And then, when you start to put in these interventions, once the interventions go into AI, they'll tell you what the effectiveness of those interventions are. Um, I haven't seen any current studies on AI. It's certainly something that we're looking into is, bringing in AI. That also will probably, hate to tell Daniel this, but it'll probably eliminate a lot of some of the nursing jobs that are not hands-on nursing jobs, is because AI, you will be able to take on a lot of that role. Again, and even, to the previous question where they're only managing like 80 to 90 patients, AI is going to help the nursing team manage a lot more patients in a higher caseload as well.
Yeah,
Do you want to add to
great.
that, Daniel, or a rebuttal that nurses remote,
No,
non-hands-on
I'm actually
nursing?
already seeing that in a couple of markets up here where I live, where they actually have a computer that they push into each room throughout the floor, and they give the patient, they're able to do their heart, lung sounds, everything, and then move on to the next room and keep going. So it's heading that way, but you're right. We haven't got that far yet. It's coming.
In question, follow up, personal question on that one, Daniel. How have you seen the reaction from the patients on those kind of interventions and technology? Are they adopting it? Are they resisting?
There's still some resistance. There is, but and that really does come down. That's why that initial engagement's so important. What we're finding is they might, if they resisted at the beginning, we're getting them on the back end, and then they're a lot more open to other avenues that we can utilize for them. Yeah. So, but yeah, which we got some work to do there.
Oh yeah,
Well, and even some of that, I think, Garrett, is if you look at the adoption of video visits, right? I
Yeah.
mean,
sure. That's a
everyone
good.
wanted to go see face to face with their doctor. Obviously, there's a lot of things you can't do unless you're face to face, but just even the time savings that you get from doing video visits is just far more accepted now, and I think with AI, that'll start to trend in that direction.
Yeah, and I
And you
think
got to make it easy.
COVID kind of forced us into that modality in a lot of senses, and I think people caught on to it and say, hey, I think this can work. This is okay. More remote patient things are all right. I did save time, and I got a good diagnostic, and didn't have to drive across town and wait in a waiting room. And so, yeah, to your point, I think it's just going to take time for these things to adopt.
Yep.
Garrett, I'm kind of glad you brought that up because honestly, what COVID, if we benefited anything from the
Yeah,
pandemic,
exactly.
uh, you know, really as a healthcare, as a healthcare providers and what we do, we found out we had to change the methodology of how we were treating patients and how we were providing healthcare. So and now we are starting to look at, we don't always have to be in the home. You know, there's
Mhm.
other avenues that we can do that for these members. I know going, kind of what that question earlier is, it's giving them that comfort. It's easy to do. I remember the first virtual visit I ever did with a member. Actually, there was someone, she had a tablet, and all she had to do was swipe the bar on the tablet, and that was it. And she said, "Well, I could have done that." It's really educating patients and letting them know it's just that easy, and that helps. So, but the methodology is, yeah, it's changing. So,
Yeah, it is. Um, all right, next question is this. What are the biggest challenges you've seen with integrating digital health tools into existing workflows?
I've
Well, I
done it
think,
this way for 40 years.
yeah,
Yeah.
That old adage, I've done it this way for 20 years. Why should I change? That's
Mhm.
probably, we've got to get out of that mode. And again, like I just, I just said, the methodology of providing healthcare has got to change. We can't just sit here, or the next pandemic really is going to get us. So
yeah, I think that getting the data out of the EMRs, depending on what systems people have, right? So getting the necessary data from point A to point B. So Epic's the mothership of a lot of this data. In with the inpatient stay, how do you get what data you need out from, and then how do you put that into a software program that specializes in care transition planning? Like, how do you know that they're on day 7 for a heart failure program versus day 20 for COPD or sepsis, right? So I think that's probably the biggest challenge, is getting the data from one place to the next, and then knowing where is each patient or member in that 30-day window of time.
yeah,
Yeah,
that's
that makes
important.
sense.
Yeah.
That makes sense. Well, let's see. I think that actually concludes all the questions that we have for today. But thank you, Mark. Thank you, Daniel, for a fantastic presentation. Obviously, there's a lot here, folks, and more to come on this. And if you would like to get in touch with Mark or Daniel or the Avery team, as we close out here, I'd like to encourage you all to head over to vbcexhibithall.com, and you can actually check out, they have a virtual exhibit booth there. And this is a way that you can really educate yourself on Avery and what they're doing, and look into some of their resources. And of course, you're able to reach out through there. The BBC Exhibit Hall Library is also where this webinar is going to be archived. And so when we get done, of course, we're going to send you a link to the recording and the slides so that you can share it and review it at your own leisure. But if you would ever like to come back and review this webinar and others on a variety of different topics and a bunch of articles and all kind of resources, you can do that there. And then finally, if you would like to reach out directly to the Avery team, you can do that here on this last slide here, Mark. I'll have you. Okay, perfect. You'll see their information here, and feel free to reach out to them, or contact me if it's easier. I'm happy to facilitate an introduction for you. But I wanted to thank you all so much for joining us for this afternoon and spending your afternoon with us. I hope you join us for the next one. And until then, have a great rest of your day. Bye bye now.
Thank you.
Thank you, guys.